Well, thank you. Thank you, Srini, and thank you to PK for this opportunity. It's wonderful to see how much this meeting has grown. So we all know we have increasing prevalence of peripheral arterial disease, and with this comes kind of more complex multi-level disease, which is also more often now including common femoral disease. When we start looking at how we treat this, and this is kind of a recurring theme we've heard from all the speakers and kind of with our panel conversation, but I think as a vascular surgeon, I still really do think that endarterectomy really does remain a gold standard. It gives you the ultimate debulking technology. It allows you to treat everywhere from the distal external iliac artery, preserve that bifurcation, and potentially treat an extended portion of the profunda, but in addition, the SFA as well. We have great technical success with this. It's nearly 100% in every study that's been described, but it also has very long-term durable primary patency. As Dr. Claire has alluded to with some of the studies, we have durable patency out to a 7 to 8 year period, showing patency anywhere from the mid-80s to the mid-90s. So while the endovascular realm of this continues to develop, what we were really comparing this to is something that gives us durability to nearly out to a decade. But ultimately, I'm very rarely doing just a common femoral endarterectomy. There's some instances where it's very focal to that, but often there's some sort of inflow lesion or infrainguinal outflow disease, or both, that we're trying to address when we're doing this endarterectomy. So the question is when am I addressing these lesions, and in what kind of clinical situation, and what am I doing for it? So when we're talking about a common femoral endarterectomy with isolated aortoiliac occlusive disease, meaning nothing in the SFA, 3-vessel or 2-vessel runoff to the foot, I will always uniformly treat the inflow lesion in the aortoiliac system. We talked in the last session about making sure you're treating your common femoral when you're doing aortoiliac work to make sure your outflow is good. This is kind of like the reverse way to think about it, but we're saying the same thing. Ultimately, you want to make sure you're concurrently treating that disease. And if I have anything greater than a 70% stenosis in the common iliac or the external iliac, I'm going to go ahead and treat that regardless of if it's a claudication, chronic limb-threatening ischemia, mostly because I know that there's really nice durability with stenting or stent grafting in the aortoiliac system. I'm always going to evaluate the common iliac and the external iliac artery, and if I need to do that, I can treat that with via the patch. So Dr. Schneider talked about potentially treating the inflow first, bringing his Viabond stent into the endarterectomy. That is a very clever way to do it. I may steal that, but ultimately that's not how I approach it. So if I have very extensive iliac disease and I want to make sure I'm entering true lumen, because when you are doing an endarterectomy, you can sometimes lift a little bit of a plane and a dissection in the external iliac, which can make it hard to navigate your wire into the true lumen once you've done that. So if you're worried about that in that case, what we can do is access the common femoral first, go ahead, cross that lesion, and then you're just going to leave the wire there while you do your patch, and then go ahead and treat your inflow. But a couple of different ways that you can approach this, but ultimately treating both the inflow and the common femoral in the setting of any kind of clinical picture that you deem need for revascularization. So I'm going to give you an example of an inflow case. So this is a 65-year-old male who has a history of rest pain, history of diabetes, former smoker, hypertension, hyperlipidemia, and he has extensive aortoiliac disease. He has circumferential calcium in the common femorals. He has extensive external iliac disease. On the right, it's completely occluded. On the left, it's stenosed, but really bulky common femoral disease. So this gentleman got bilateral common femoral endarterectomies. And you can see here with the pigtail up from the left side, you still really do not have any flow coming through that right side despite an extensive endarterectomy. So we have to now start treating that inflow into our endarterectomy sites. So started off here with kissing. I actually used IVL, and there was a question earlier about could you use bilateral kissing IVLs. And if you don't happen to have two generators or you don't want to go into that expense, what you can do is you can still use a balloon on one side to protect yourself for the kissing balloons, and then just swap your IVL on either side, which is what I ultimately did here. Ultimately used bilateral VBXs to kind of build up a little bit into that bifurcation. And then on the right side, use a self-expanding stent in order to preserve the hypogastric artery. And it's important to know when I do a femoral endarterectomy, I'm often trying to take a nice plane and almost an eversion endarterectomy from the external iliac artery so I can land that stent into that portion of the endarterectomy. So I have a very nice smooth transition from the external iliac artery stent into my endarterectomy, because if you leave a little intervening space, that's a really high rate of area where you can get restenosis down the road. when we start looking at these hybrid approaches of common femoral endarterectomies with retrograde iliac stenting, both for task A and B lesions and for task C and D lesions, when you compare them to open surgical procedures, they're having very equivalent outcomes. I think that's due to the durability of our stents that we have and also kind of the larger diameter size that we're able to get these stents to. When you look at some more longitudinal data from Dartmouth here, they were looking at retrograde iliac stenting for common femoral endarterectomies through a whole course of clinical symptoms, right? So rest pain, tissue loss, and for claudication, where you have complete occlusion of the external versus not. And what you can see is that over a 6-year period of time, primary assisted patency and secondary patency rates are quite excellent, almost near 100%, with a dip in primary patency down into the 60s at the 6-year period, but assisted and secondary patency being quite high. So when we're doing a femoral endarterectomy and we're thinking about doing a hybrid approach and what we're going to do, there's 2 things I really consider with how I do my endarterectomy and whether I'm going to do additional adjunctive endovascular therapy. One is what are the symptoms am I treating? Am I treating a claudicant or am I treating someone who has CLTI who needs inline flow to their foot? And then I also want to know the underlying patency and disease of the superficial femoral artery. So when I think about the profunda artery, I think the profunda artery is one of the most important arteries in our entire body, right? And so you want to make sure your endpoint into the profunda is clean and you're not going to stenose it or cause a dissection flap. So sometimes the plaque will evert nice and easily and I don't have to do anything, or maybe I just need one tacking suture to make sure everything flows nicely, but sometimes I don't, and it really extends down. Just like that case we saw today, that is a case where automatically I'm taking my arteriotomy way down onto the profunda, debulking all of that and endarterectomizing all of that in order to get a nice clean endpoint in the profunda. Because ultimately, if your SFA goes down in the future, your profunda is going to keep your leg alive. Now, with regards to the superficial femoral artery, if it is patent or you have just mild disease, you also want to make sure that in your endarterectomy, you're not creating a flap and inhibiting the flow into your SFA. So that may mean you're putting tacking sutures, or that may mean if you've already gone down onto the profunda with your arteriotomy, you may also be going down on your SFA and you're doing a Y patch in order to preserve both of those. Now, if your SFA is occluded, this is when you really have to start thinking critically about the patient, and you can see, we even talked about this on the panel today in this patient who had an occluded SFA and very significant inflow disease about whether we treat that SFA or not. So in my algorithm, if the patient is a claudicator and they have significant inflow disease, something that's really inhibiting the profundas, which is providing your collateral pathways around an occluded SFA, I tend to just do the endarterectomy, and 7 out of 8 patients, out of 10, will have enough improvement of symptoms where you actually don't need to treat their SFA. And as we all know, the durability of SFA interventions is not the same as compared to the aortoiliac interventions. Now, even when I do this, so if the SFA is occluded, I will make sure to do an eversion endarterectomy to kind of pull out the origin of that. So if I do have to come back, I have a little nub to shoot for, and I don't have to bring a stent or scaffolding all the way up to the origin of the SFA, and I can protect that profunda. Now, if it's this very severe claudication, or I get in there and the common femoral just wasn't quite as bad as I expected it to be, at that time I will go ahead and perform an SFA intervention in order to kind of relieve the patient's symptomatology. If it is chronic limb-threatening ischemia, we're automatically in the same period of time doing some sort of SFA or popliteal intervention in order to provide inline flow to the foot. So when it comes to treating the SFA in these situations, there's a lot of options, right? We have debulking methods, we have IVL, we have drug-coated balloon angioplasty and drug-coated balloon stenting, we have biomimetic stents, and we have covered stents. So we have a lot of options, and I would be remiss to say as a vascular surgeon that we don't also have bypass options in this situation as well. And again, we're kind of looking to best CLI and the global vascular guidelines to picking out the right patient who have the right conduit, good patient protoplasm, who we may offer that to, as opposed to an endovascular approach to the infrainguinal disease during your common femoral endarterectomy. But here, let's quickly look at a case of a patient with infrainguinal disease who needed a common femoral endarterectomy. So this is a 74-year-old patient who had prior kissing iliac stents, extensive common femoral disease, but no GSV, prior CABG, not a good bypass candidate, heavily calcified plaque and rest pain with now dependent rubor. So this is what it kind of looks like when you go ahead and you start to do your antegrade work once you've already done a femoral endarterectomy in the setting of an occluded SFA. You kind of get this stagnant column of contrast. It'll backfill into your profunda, and you're hitting this occluded period. Now, what you can do is in this situation, not only can you take your patch onto the SFA, but you can even extend your endarterectomy more by kind of everting and pulling out that plaque. So you have a nice runway to do your intervention. Ultimately, the profunda came back with what looks like to be potentially PT and perineal runoff. So with this was recanalized antegrade and kind of went right through the true lumen. So ultimately ended up doing some intravascular lithotripsy and was able to get away with drug-coated balloon angioplasty and avoided scaffolding in this situation to give the patient 2-vessel runoff to the foot. So when we look at the literature that's behind common femoral endarterectomies with endo interventions for the SFA and POP, there's not a ton of literature out there, and probably a lot of the patency data is going to reflect what we see in our specifically just SFA popliteal studies. But ultimately, there is evidence that with regards to long-term durability in single-center studies, that this does provide comparable outcomes to SFA interventions alone. So in conclusion, with the increasing rates of very complex disease, and particularly in calcified arteriocclusive disease, a common femoral endarterectomy, common femoral disease that is significant is becoming more and more prevalent. While I do think endovascular interventions play a role, certain patient populations, and as we've all talked about here today, we don't really have great long-term data to compare one to the other. We don't have randomized controlled trials. In my mind, I think a common femoral endarterectomy is the first choice. It's the gold standard. And an endo intervention really is kind of the exception to the rule. A hybrid inflow or outflow treatment is becoming increasingly common, and I believe that an inflow treatment is mandatory if you're going to undertake an endarterectomy with inflow disease, and then it's really kind of clinical scenarios, patient-specific, whether you're treating the outflow disease. And so with that, I'd like to thank you very much for this opportunity.